Right atrial enlargement. The right atrial enlargement is still looked at by looking at the height of the RA and the rightward shift of the right heart border. So we have few objective criteria which I enumerated in my slides. 5.5 centimeter from the midline or 3 centimeter. You can't measure 5.5. Okay, but we do have a scale at the side. So with digital X-rays, we have a scale at the side. Even if you zoom in or zoom out, the scale also zooms in and zoom out. So you can make those measurements. And again, sir, the height of the RA, if it is comprising more than half of the right heart border, usually it's an enlarged. How many of you know that so-called half height of the right atrium? Can you draw those lines? It does not usually take place. In order to draw those lines, most of your blind. You will tell the client. Okay, it's you can assume that the upper part of the aortic arch forms the first line, and where you see the notch, where the SVC, there is a change in contour at the point where the SVC joins into the RA, and the third point will be the right cardiophrenic angle. So this is the entire distance, half. If this comes up, you will say that it is more than half of the right hand border. That implies you draw those lines, and if the RA upper border goes above that, then RA. Okay. Thanks. So the next 1 hour is a quiz on ECGs. Dr. Balbir and Dr. Narasimhan will conduct the quiz. May I invite them on stage?
So this is going to be an interactive session, and I'm lucky that I have my friend Narasimhan here, and it can make the program look very interesting. So it's all case-based. These are cases which are real-world cases, and there is no theory, all practical. So can we have the slides? Okay. So this is a gentleman who is 46-year-old, no past history of heart disease. He felt palpitations, and he had an Apple Watch, and he recorded a tachycardia. Alert was given, and he came to the emergency room. Now he started feeling uneasy. He knows this heart rate is fast, and 145, and he's uneasy. And let's see, this is the ECG that we carry out in the emergency room. So this is the ECG. You see the rate is fast. You see the ST segment, V4 to V6, and this is the rhythm. So you can spend a minute on this and think what before the next question is put. Do you have the
audience response system? Do you have an ARS for them?
Have you given?
It doesn't matter. One of you can.
So before he sets up this, let's go through this. So the question here is, how many of you think this is sinus tachycardia that he's come? Sinus tachycardia and has some STD changes. How many of you think? There is none. How many of you think that he has sinus tachycardia and he's having chest pain, uneasiness, and he's probably got ACS and needs to be treated? It's not unusual a 46-year-old to start with a ischemia and have sinus tachycardia and come to them. None. How many of you think there is atrial tachycardia and there is ischemia? Both. None again. How many of you think it is atrial tachycardia with 2:1 block? So there are many. How many of you think this is atrial flutter? None. Okay.
Yeah, let me just go to this. You said it's atrial tachycardia with 2-to-1 block. Can you give a beta blocker for him? Delta SM or beta blocker? Speak up. No, can we give for this person because he has got a 2-to-1 block? Because there's 2-to-1 block, you're right. What were you saying? So, no, that is okay. You made a diagnosis. In terms of treatment, so this is one, actually it is not, this is physiological. In you and me, when the atrium fires at a rate of 200, physiologically the AV node cannot conduct. So this is called as 2-to-1 conduction. So you can safely give, very often this is a misconception that you don't give a AV nodal blocking agent. You can escalate the drug. The clue there is you should have a memory of what a sinus P wave looks like. Is it not coming up? Sinus P is always biphasic in V1.
Why is this not coming? The history is not coming here.
So, such of you who are there, you have to go back to the basics. The right atrial activation followed by a delayed left atrial activation. Left atrium is a posterior structure, so the wavefront will move away from the sternum. You will invariably have a biphasic P wave in a sinus P wave. When a P wave is completely positive in V1, it means all the wavefront is coming from posterior to anterior. Do you understand what I'm saying? So this is clearly an atrial tachycardia. This is not a sinus tachycardia. And such of those, when there is a 2-to-1 conduction, this patient, how will he generally present? They may not be very symptomatic. The classic symptom is the moment he walks, he climbs up stairs, he'll become very symptomatic. Why?
So now if you see, you try to first understand, can a sinus tachycardia have 2:1 block? So can the heart rate sinus go to this level? So 300 beats per minute sinus can't go. So it has to be somewhere else. So we now clear that this is a P wave, this is a P wave. For atrial tachycardia versus flutter for your level, flutter has to have this isoelectric line should not be there. You see this isoelectric line? So there is no saw-toothing pattern. So it is against flutter. Normally, if you had slight saw-toothing, it could have been flutter because it fits in atrial rate of 300 and ventricular rate of 145. So it fits very well. But the other thing is, if you look at P waves, this is upright. If it was typical flutter, you would have expected a negative P wave of 2-3 AVF. They're all positive. Now this indicates that this atrial tachycardia is arising, as Narasimhan said, this P wave is all upright. This can only happen. V1 is an anterior lead, it's right here. It can only happen if something most posterior is coming up. So it has to be an LA. LA is the most posterior. It could be a pulmonary vein. The most posterior structure is going to make the most positive P wave in V1. So if we think that this is LA, then it has to be superior part of LA because you have 2-3 AVF as positive, again indicating that the impulse is from the roof or the top of LA. So it's not only an atrial tachycardia with 2:1 block at your level, you should be able to tell whether it is left atrial, right atrial, whether it is from the upper part or the lower part. There are very good clues to tell from the ECG. Can we go to the next?
Do you think this patient is in heart failure? When you see a discrepancy between precordial leads, voltage, and the standard limb leads, look at 2-3 AVF. It's all just about less than 8 millivolts. Next, ECG.
Previous ECG. No, pitch.
Give the control to Dr. Balbir. See the V5, V6 all quite tall. Voltages are all over the place. Whereas 2-3 AVF, AVL and all are very minuscule. That is typically seen in patients with waterlogging. Why? So you measure in bipolar lead, you measure the difference in voltage between right arm and left arm or right arm and the left leg. when the tissue water is waterlogged, subcutaneous tissue, there won't be a potential difference. You understand? So the voltages will attenuate. You give some diuretics, patient's heart failure improves, this will improve.
So you see, this is called the discrepancy between the limb leads and the chest leads, right? Achha, theek hai. Theek. Okay, we go to the next ECG, which is a patient who comes with palpitations. Okay, this guy comes with history of pre-syncope and nothing much. He has been reasonably well, no past history of heart disease. But nowadays, after the COVID, patients have started checking their pulse, put on the oximeters, and very particular about their pulse and saturation. Now he finds an irregular pulse and comes to the OPD with me. He's a diabetic, hypertensive. BP is little bit on the higher side. BP is little bit higher side. Chest and CVS are normal. This is the ECG that he comes with. I give you time to see. So this is lead 1, 2, 3, AVR, AVL, AVF, V1, V2, V3, V4, V6, right? So these are the leads that he has. And he's in your OPD, he's saying, I'm feeling well. I don't feel anything, but I feel really concerned that my pulse is irregular. And that's all. You can see his heart rate is 78, blood pressure is fine, and this is what his ECG is. So, what are we dealing with? दे दिए वो? So everybody has the, और वो उसका result कहाँ आएगा? यही का है. अच्छा ठीक. So you can mark in your timer start. So we are starting the time. You can give your response. First is, it's a acute coronary syndrome. We need to do an angio. It's a high-grade AV block. It needs admission. It's a Wenke back and can be investigated with a Holter. Has VT with AV dissociation. So we have an interesting response. Most people would think that let's let him go home. So let's go back to the ECG. So how people would have missed this. Okay, so if we start with this rhythm strip, first this is a right bundle branch block. So bifascicular block is clear, right? If we start with this rhythm strip, let's go here. So there is a clear 2:1 block here, right? So mark my words, if you have a 2:1 block with RBB or LBB, it has to be infraeasing until proven otherwise. You can have, I don't say that you cannot have an AV node with conduction system disturbance, but there is a very high chance that this person has a AV block. Now, if we look at this leads, this PR is short, almost normal, rhythm strip. This PR is longer. Then there is one complex which probably the P has fallen on this and this has conducted. If we look at the QRS here and here, this is probably a little broader than this QRS. And this QRS is similar to these QRSs. Then again, a same thing happens. One beat conducts and then PP comes and then we initiate 2:1 block, right? So this is the only odd beat which in my opinion was a supernormal conduction. And this can happen. Supernormal conduction happens when you had a prolonged PR, so there is some time for the recovery of the bundles. So supernormal conduction happened here and then it blocked off. So this patient is high likelihood of getting into trouble, should be immediately admitted and thought about what's happening. So this patient was advised admission and he was kind of still thinking when he had another pre-syncopal episode in the OPD itself and felt dizzy and almost about to fall when he got admitted. And this is the tracing what we have on intracardiac tracing. So we will go through this very carefully. So this is the His bundle catheter. So this is the A and this is the A, and this is the H. You see, this is the H, right? Can you appreciate A, H, and V? So this is A, this is H, and this is V, right? So you can see the HV is markedly prolonged. AH is short. So this is the H, this is the H, HV is prolonged. Now what happens here? Let's follow this tracing. Very interesting. So this is the HV, this is the HV which gets longer than this HV. This HV further prolongs and the next one blocks off. So this is a Venki back happening in the infraconduction system, right? So you have bifascicular block and now you're conducting on the left bundle. You prolonged slowly on the left bundle. That means the left bundle is also diseased and this is a high grade AV block. This patient cannot do without pacing. You cannot leave this patient without pacing. If you had given this patient a Holter, next morning probably he would have come with PPPP on the Holter.
What's abnormal in this? Physiologically, what is abnormal? Venki Bach is generally a feature of the AV node. It's a calcium conducting structure. Sodium conducting structure like his, generally as the rate increases, it will accommodate for the shorten the refractory period. When you see the his bundle having a Venki Bach, it's always diseased. It's not, whereas Venki Bach is a normal phenomenon of an AV node. It's always pathological in the his. Am I clear in what I'm saying? And the clue in that previous ECG is, if you see a PR that is normal after a block beat, you see the previous beat is normal P is blocked, again it's normal PR. Whereas if it's a nodal disease, the PR should have stretched and then blocked. So this patient has a disease of both the AV node and the his, which is not uncommon. In literature, it's almost about 30%. Elderly patients will have a disease of both the AV node and the his.
So, all Venki Bachs do not mean AV nodal disease, do not mean innocuous disease. Look at the bundle branch block. Be careful if you have a Venki Bach with a bundle branch block. This is a high likelihood to go into a high grade AV block like this patient. Okay, let's look at this 26-year-old gentleman. He comes with the history of pre-syncope and palpitation and is in the emergency room feeling uneasy. His BP is normal. His saturations are good and his chest is clear. So he's not in failure. And this is the ECG which looks horrifying, horrendous. But the patient is not so bad. And what do you see on the ECG? So let me give you some time to think because there will be some questions following this. So you see all the leads are there. Lead 1, 2, 3, AVR, AVL, AVF, V1, V2, V3, V4, V5, V6. Okay. I'll go to the question and then come back to see the ECG unless somebody wants to still think. So some of the interesting things in the ECG which I can help you is look at this beat. You see this beat? Look at this beat. Right? It's giving some clues to you. What happened here? So, what is contraindicated in this patient? DC cardioversion, flecainide, IV amiodarone, or IV diltiazem? Oh, all split. So there is maximum is 35% think diltiazem is contraindicated, and some people think codron is contraindicated, flecainide contraindicated. DC cardioversion 10% think it is contraindicated. So now, does anybody want to come to the mic and try to analyze this ECG? Because I don't want to go back without having given a description of the ECG, because I have seen people die because of some wrong drug selection. I know I have seen during my years of cardiology, when we got ECGs, how a patient died when the wrong drug was given for this kind of arrhythmia. So, does somebody want to come up to the mic and try to analyze this ECG? It's very important to analyze this. So, first striking thing is that, what is this? What is this? I don't want this. Okay. So the first thing that strikes you is that this is an irregular arrhythmia. Clear? So any doubts on regular or irregular? So clearly irregular. Second is, if you look, when this rhythm becomes very fast, if you look at the RR interval of 2 beats, the rate is around 300. Agreed? So it is very fast, irregular tachycardia. And it is broad. Third thing is that you have some 2 beats which are like absolutely normal looking beats. Right? So this is the third clue. So you have a fast, broad and irregular tachycardia in a young individual, 26 years of age. There is to be one diagnosis, that is atrial fibrillation with WPW syndrome. So you can't give digoxin, beta blockers or delta to such patient. It is absolutely contraindicated. Then the next thing is, when you get this ECG, you know that some of the beats are fully pre-excited. That means what is happening is, some of the beats are going all through the accessory pathway. Some are trying to fuse, and some have actually not crossed the pathway because it is blocked and going through the AV node. So you have 3 kinds of fusion: fully pre-excited and absolutely normal. So this is an absolute normal beat. It has gone through the AV node because the accessory pathway got blocked. Then you see some of the impulses are much broader than the others. These are broader than these impulses. They're going through the pre-excited band, but not through the AV node. So you have 3 kinds of beats in this. That also is the second clue. And third clue is, if this patient is going for a ablation, the electrophysiologist, it's a very important ECG, because now it's all pre-excited beats. He knows where the location is. He doesn't have to rely on the sinus rhythm ECG. He can map out. So V1, V2, there's a distinct change, and it suggests a septal location. And 2, 3 AVF are negative. So it suggests a post-septal location to the ECG. Before we go to Narasimhan, any questions from your side? Because this is something which should be memorized by you. This ECG should be a part of your life. As long as you practice cardiology, you should not make a mistake again on this ECG.
Yeah, this is a life-threatening emergency and patient can be completely cured. This is one situation where the ablation is a curative option. What is peculiar is, this is called reverse pattern break. You look at V1, it's completely negative. V2 is completely positive. And then V2 becomes again, it loses the R wave. It's called reverse pattern break. That is because where the V2 is, it's directly underneath that is the pathway. It's usually an epicardial pathway. There are clues here to suggest it's an epicardial pathway, reverse pattern break.
So now this patient was cardioverted, and I will show you the ECG after cardioversion. So hope it is clear now. You see a delta wave. This is the delta wave. You see a negative delta wave in 2, 3 AVF, right? And you see this pattern change from V1 to V2. And this patient had an ablation done in the middle cardiac vein, as Narasimhan was suggesting. And this is the ECG after ablation. Now, middle cardiac vein is touching the crux of the right coronary artery and the posterior descending artery. So the middle cardiac vein is kind of at that junction where the right coronary. And he gets these changes. You know, he's also complaining of some heaviness in the chest. And he gets these changes. You see these changes in the inferior leads? So how many of you think that you have to take this patient back to the lab and rule out coronary ischemia? And why did this T-wave inversion happen? So none of them, you think it's normal or it's abnormal? So how many of you think normal? This is normal. Yeah, very nice. So this is very good. So this is a memory T-wave change. So if you ablate a pathway, after that you get T-wave inversions, which is a memory sign because it is a repolarization which has changed from what it was earlier to what it is now. And this comes as a T-wave inversion. And this disappears over a period of time. And you shouldn't really bother and take the patient to the lab to say, oh, coronaries must have occluded. So this is a 76-year-old lady with palpitations. Many past episodes, feeling uneasy now. BP is fine. She was on beta blockers and non-diabetic. This is the ECG she gets. I'll show you another one. So this is the ECG. So these are chest leads and this is the limb leads. So you see, these are the T waves, clearly peaked, nothing here. The narrow QRS rate you can see about 140, and she's uneasy. These are the chest leads, and she is in the age where you have to suspect everything. This some STT changes here, more ST here. You see this V5, V6, right? Go back to the same ECG. Okay, I don't have a question here. So, does anybody want to come up and try to analyze this ECG? Because I know the diagnosis and we have done everything. And somebody should come up, or I'll ask somebody to come. Who wants to give it a try? It's always a good thing to do that. You're not going to be wrong. We'll help you. Yeah, please come.
Even if there is nothing, you say, is there a tachycardia? If there is a tachycardia, is it regular or irregular? And can you decide?
Narasimha, take the mic.
So is there a tachycardia? Rates are more than 100, there is a tachy. Is it regular or irregular? What is the relation of the P to the QRS? These are the three things you're just going to describe. So this is narrow QRS or wide QRS? Narrow QRS. Is it regular or irregular? Regular. And what is the relation of the P to the, where do you think is the P wave?
So where do you think is the P wave is the most important question? After QRS? So this is the P wave? Good. So, it's so simple. Even if somebody had said it's a narrow QRS tachycardia, I think it's a supraventricular, I'm very happy. But you have to make an attempt. So it can't be a sinus tachycardia. Can it be a sinus tachycardia? This is we don't need all these things. So if you look at this P wave, it is just outside the QRS, right? Clear? And then it is followed by a T wave. Now this P to PR is not possible. You can have such a long PR, but then it is not a sinus P wave. It is an inverted P wave, so it cannot be a sinus P wave. So you have a differential diagnosis of three arrhythmias. It could be a AVNRT. In elderly, the VA conduction is not so fast, so the P wave can come out of the QRS. Normally, the P wave is merged in the QRS, so you don't see an AVNRT. But in an elderly individual, it is not uncommon that you get the P wave outside the QRS. And sometimes it forms a pseudo S because if this P wave comes here, it will become a pseudo S, right? You understand? If this P wave was here at the tail end of the QRS, it will come as a pseudo S. Okay, so this is how AVNRT. The second diagnosis will be a concealed AVRT, concealed pathway. That this is a retrograde P and is a the PR is shorter, RT is shorter than PR, right? And the third differential diagnosis is that it's an atrial tachycardia, that the P wave is here and then it's conducting with a long PR window. Okay. So these are the three differential diagnoses of this arrhythmia. Narrow QRS tachycardia, regular relationship between PR, P to R is RP is shorter than PR and it has only three differential diagnoses. Simple. Narasimhan, anything else?
By law of averages, you don't have a person at 76 for the first time presenting with an accessory pathway mediated tachycardia. It can occur, but it's unlikely. And this kind of an incessant tachycardia, the location, the narrow, look at the width of the P wave. Is it narrower than a sinus beat or broader than a sinus beat? The P wave, and its activation is from inferior caudocranial activation. So that is an inferior structure. The P wave is starting from the base and going towards the sinus node. So it's going from AV node to the sinus node, and it's somewhere coming from the midline. That's why the two atria are simultaneously getting activated. The P wave becomes narrow. So the structure there is either the coronary sinus or a slow pathway. It's an atrial tachycardia coming from the os of the coronary sinus, or that is where the slow pathway is located.
Okay, so this patient underwent an EP study with an AV nodal re-entry tachycardia, which is a great success for us. She's fine. Let's go to the next. So this is a young guy, 22 years old, comes with one of the ECG, okay, and I will show you another one. And this is the next ECG in the exmorphs. We go back to the previous ECG. This is one ECG, same patient. Here the rate is 112. This is another ECG. And this is his echo report. His echo ejection fraction is 35 to 40. So he has a cardiomyopathy. It's a global hypokinesia, and the PA pressures are a little bit elevated. 36 is the RV systolic pressure. And this is the same patient with this ECG and this ECG. So we go to the question. So what is the rhythm? Atrial tachycardia, atrial flutter, atrial fibrillation, or a multifocal atrial tachycardia. So we can start the response. So half of them think it's atrial tachycardia. So why is it important to diagnose this arrhythmia? Now you have a patient who has LV dysfunction. He's a young guy, 26-year-old guy. He comes to you with this kind of a tachycardia. And if you look at this ECG first, you get stumbled. You get stumbled because he goes into the tachycardia, then he stops here. But this P wave is not looking normal. This is not a sinus P wave. Then he goes into this, then he runs into this, and then he goes into this. Now, if you try to look at the P waves, this one is the first P wave. This P wave is on the T. You can see the peaking of the T wave. Then this P wave comes, then this P wave comes, then this P is here, but it is blocked. It is not conducted. Then it starts with this P wave. You look at this peculiar looking P wave. It matches this P wave, it matches this P wave. Lead 1, if you see, is negative, right? Lead 1, the P wave is negative, clearly negative. This one is negative. So this is another P wave. So it is very easy for some people to say it's a multifocal atrial tachycardia. You know, we were taught in MBBS days of multifocal tachycardia. I think it's a kind of a misnomer. I don't agree with that diagnosis. Most of them are formed in first year of atrial fibrillation. You have to be clear, in a 26-year-old gentleman, making a diagnosis of multifocal atrial tachycardia is asking for trouble. So these P waves, since they are marching into the T waves, the morphology may look different. But he announces next morning that he has only one tachycardia. He has lead 1, which is negative. You have very peculiar kind of a P wave in 2-3 AVF. V1 is kind of flattish, V2 is negative. Okay. Now, if we try to decipher this, if you look at lead 1 and AVF, they are leftward leads. So, extreme leftward leads are 1 and AVF. So, the impulse is moving from where? It is moving away from the left side, right? So, it is on the extreme left. V2 is negative. Okay. So, V2 is a lead here. So, again, it is moving leftward. So, it has to be a peculiar tachycardia. And this was a unifocal tachycardia. And I'll just show them. Okay, I'll just show them. You want the previous one, the first one? Okay.
So the rate of this versus the rate of the other tachycardia, is the rate constant or is the rate varying? So does that give you any clue about the mechanism of the tachycardia? Warming up and cooling down. What does the mechanism? It's usually automaticity. Okay, there are certain structures in the atria which have automatic cells with like sinus node like properties. And the very interesting, V1 is upright, V2 is again a pattern break. You see V1 is upright, V2 is inverted, again V3 becomes upright. So what it means is the tachycardia is coming from a structure exactly where you place the V2 lead. The V2 lead where you place in the chest, what is the structure underneath, the atrial structure underneath that? You look at the topography, I think it should.
Sure, you know. So, this was, can we play this? This is a video, please play. So we mapped it. I'm not showing you the map, but I'm showing you the catheter. So this is the catheter in the LA appendage. This tachycardia was coming from the tip of the LA appendage. Now, if you look at LA appendage, it curls around the left border and comes anteriorly. So it's an anterior structure, right? So it is sitting somewhere under the V2. So that's why V1 was positive and V2 was negative. So if this structure is sitting just below the V2, only then V2 can be negative. Do you agree? So LA appendage, very leftward, then curls and comes. So if the surgeon opens the chest, LA appendage is sitting right there on the left border. And what happened to the screen? So this is where it was ablated. Next slide. And this is the ECG next morning. So what do you think would happen to his ejection fraction over a period of time? Worsen is a cardiomyopathy. Will it worsen over a period of time? He's a young guy. What will happen? Normal? Normal? Or recover or not recover? So this is a tachycardiomyopathy. So it becomes so much important for you. Can you go back, please? Go back. Go back. Go back. So I would tell you many cases which have gone, go back please. Go back. Go back. Go back please. Okay, so many patients in the past have been treated in heart failure clinics, this being labeled as sinus tachycardia, and they have continued to deteriorate in the ejection fraction and never improved. And unless you look carefully at these P waves, anybody can get fooled that he has 35 to 40% ejection fraction, he has heart failure, his PA pressures are high, increase his diuretic, add beta blockers, let him go like this. You are actually missing a great opportunity to improve his ejection fraction. You are actually doing very injustice if you don't look at these P waves. There have been several examples where it looked similar to sinus tachycardia because it was arising close to the sinus node in the upper part of the crista. But there were clues on the ECG of warming up sign or some other clues or a fixed rate. The rate doesn't change much. You may manipulate with drugs, the rate doesn't change much. There have been crista terminalis, upper crista terminalis, atrial tachycardias where we ablated and the patient's ejection fraction improved. So any patient, a young patient who comes with low ejection fraction, a careful thought on the ECG as to what can be there. Now, if you look at the voltages, they're so nice against any dilated cardiomyopathy. But over a period of time, if you let him in this atrial tachycardia, he will actually deteriorate and get all those signs of cardiomyopathy. But another thing is, it's very interesting that this rate is not too fast. It's 128. But atrial tachycardias, even some of these were ill-sustained. They would break, as I showed you in this patient. But interestingly, how the ventricle responds to an atrial impulse coming from another direction, from a sinus beat. A sinus beat rates of 110, 120 would not lead to LV dysfunction. How can an LA appendage tachycardia with similar rates can lead to an LV dysfunction in cardiomyopathy? It's very interesting.
What is the mechanism? Why does an atrial tachycardia at the same rate causes tachycardiomyopathy, whereas sinus tachycardia 110 doesn't cause cardiomyopathy? So in sinus rates, it's under vagal influence, whereas ectopic nests are independent of vagal influence. So vagus, when you go to sleep, the same patient with a sinus tachycardia of 110 during the day will go down to a heart rate of 70 or thing during sleep. If you see an absence of diurnal variation, you should think of an ectopic atrial tachycardia. What Balbir was saying, sometimes if the tachycardia comes very close to the crista, high crista, morphology-wise it will resemble a sinus tachycardia. But the clue is, you won't, especially in children, you won't have a nocturnal vagal influence will have no effect on the tachycardia. Do you understand? So 24/7, if your ventricle is bombarded at a rate of 128, it will start failing. That is the mechanism.
So one of the good clues is to do a 24 hours Holter. And if the nighttime heart rates continue to be similar to what the daytime heart rates, it's a very important clue that it could be an atrial tachycardia. And PVF morphology is generally a clue except in the upper crista where it could resemble a sinus node. And we have been fooled several times. We've been missed these ECGs in many heart failure clinics, and patients have actually suffered.
Balbir, they want us to close. Probably the last ECG we can do.
Okay, let's look at this important ECG. So 26 years old lady comes with 2 episodes of syncope. Multiple investigations done in the past have been negative. She has a normal ECG, normal QRS, going around with no diagnosis until multiple Holters and until one Holter picked up something. So this is the Holter which picks up something. So this is the Holter which is abnormal, and she almost fainted during this Holter, and she's just 26. So what are the things? Is it a vagal reaction? Is it a paroxysmal AV block? Is it a infrahesian block? Or it's an artifact? You know, you have to take a decision for a 26-year-old lady. Multiple tests have been negative. The decision you have to rest is, does she need a pacemaker or she needs to just be said, no problems. So 47% think that it's a paroxysmal AV block, and some people think it's a vagal reaction. So go back to the slides. Okay, now if we look at this kind of arrhythmia, that suddenly she was going fine, her QRS is narrow. That one thing you have to remember, the QRS is normal. If this QRS had been brought, the times would have been simple. Then we would have been looking for some inflammatory myocarditis or something which could cause these blocks. But QRS is normal. and she suddenly gets very high degree of AV block. You see multiple P waves getting blocked. This can happen in two conditions. A vasovagal can produce this, or a paroxysmal AV block. To distinguish between these two conditions is that if you look at this PP interval, it is not that long. In a vagal reaction, you have to have sinus bradycardia in addition to an AV block. You cannot have it. So paroxysmal AV block is a dangerous condition, happens in young individuals, and it lies in the intrahisian pathology. In this patient, we could prove that there was a block in the intrahisian. There were 2H at the his level. She got a pacemaker. This is about 6 years back. She has used it very few times. So it happens very occasionally, maybe once a year or once in 2 years, this will happen. But when it happens, it causes severe syncope because it is, and it's a very interesting condition that even if you give a VVI pacing to these patients, it's enough because they don't need too much of pacing. But this classical thing is that you have PP which is not too long. That means the sinus is not so slow, but the block has happened. So it is unlikely to be a vagal reaction. This is a typical of a paroxysmal AV block. So it's a condition which very few people actually know, and what you don't know, you will never see. Your eyes will not see what your mind doesn't know. But in a young individual, missing this diagnosis can be risky and important. So this patient needs a pacemaker. Last comment and then
These are very important. In this age group, when you see AV block, you need to look for other conditions. Like Dr. Balbir was saying, inflammatory cardiomyopathy is one. And second thing is some of the SCN5A mutations, some of the sodium channel mutations can initially present as an AV block because his is a sodium channel dependent structure. So you will first have problems related to his bundle or atrial arrhythmia, and then they'll develop cardiomyopathy. So you should keep it at the back of your mind.